All right, hello everyone, and welcome to today's virtual panel discussion brought to you by Indiana Healthcare Executives Network. My name is Vishwa, and I'm your session host representing the National Office of the American College of Healthcare Executives. We're so glad you're here, but before we get started, I want to go over a few items to help you navigate the program in our virtual environment. For the purposes of noise control, your lines will be muted for the duration of the session. The chat function will be available throughout the entire event, so please utilize that for questions and comments and make this as interactive as possible. The event is being recorded and will be available for viewing in ACHE's Learning Management System in approximately 2 business days. Today's session is worth 1.5 hours of ACHE face-to-face education credit, and to earn this credit, you must be logged in for the entire duration of the event. All attendees who meet this requirement will have their credits applied within 2 weeks from today's event. Lastly, we encourage you to complete the evaluation for this event. The link will be in the chat box as soon as I finish speaking, so please take a look at that before we close out today's session. And now to begin, let me turn it over to Sean.
Good afternoon, everyone. Thank you for joining us for this wonderful program that we have for you today. Before we get started, I wanted to take the time out to thank our sponsors, because with their support that we can provide programs such as this to our members. I want to say a special thank you to Ice Miller for being a premier sponsor. I also want to thank Heapy for being a platinum sponsor. Thank our gold sponsors, Imbicare, Arc Design, Cornerstones, Cat Saper, and Miller. Again, thank you all for your support. All right, now let's dive into our program. Thanks again for joining us. We have an amazing and well-rounded panel before you today to discuss RN and clinical staff retention and turnover. We have our moderator, Dr. Christy Artuzo, Chief Nursing Officer at the Richard L. Rodebush VA MC. We have Stacy McCreary, Founder and CEO of the ROI Search Group. We also have Leanne Blue, Chief Nursing Officer at Eskenazi Health. Rounding out our panel is Michael Kuhn, Director of the Emergency Department, Heart Station House Supervisors, and Transportation Nursing Administration. I'll now hand it over to our program moderator, Christy.
Thank you, Sean. It's a pleasure to be here today, and welcome to all of you. We are really looking forward to the opportunity to have a conversation with you and to really go through a few hot topics about nursing retention and recruitment, which are affecting all of us in the healthcare industry currently and likely for the next decade. The panelists have all received these questions in advance, and they have some wonderful information to share with you. But we also welcome your questions through the chat room. I'll be moderating and looking at the chat room at the same time. We may take some questions during the exchange, and the majority will be answered probably at the end of the program, so that we have plenty of time to make sure that we get through the program content and answer as many questions as we can. So with that, I'd like to get started and begin with our first question. And our first question for our panel is, with more baby boomer nurses retiring and young nurses entering the workforce to replace them, what are you doing to pass that rich experience and institutional knowledge on to onboarding RNs? Leanne, would you like to kick us off? Oops, you're on mute, I think.
I forgot to turn off that darn mute button. 2 years and however many months into COVID pandemic, and I think that's the #1 issue I hear from everybody on Zoom and WebEx and Teams and whatever. So, and that would probably be because I'm a baby boomer and the technology doesn't flow as well. But well, thank you for inviting me to participate today. Right now, what you just brought up, transferring the knowledge from a generation of nurses that have practiced for quite some period of time to our newer nurses is really critical. And so some of the things that I see nursing in general do, and I want to share that I'm on the Indiana Center for Nursing and also the Indiana Hospital Association for Workforce Development. So we talk a lot about workforce needs over the years, but right now this generational impact is really important. So some of the things that I hear and what I've applied where I practice at now is what we call a skills boot camp. and just really trying to help new nurses that are coming on board to learn skills, especially during this last 2 years. The clinical rotations for doctors and nurses and other caregivers has not been as rich as it had been in the past. So doing some skills boot camps, as well as the nurse residency program, the transition into practice, really identifying not only a preceptor for a new nurse, but a mentor to help them through that. We also have our fun WebExes, learning from each other, just to touch base, check in, that we used to do in person, but that also allows some opportunity just to ask questions and provide a safe place. We call them our coffee chat sessions, and just opportunities for new nurses to ask the questions that they're afraid to ask, or they've seen something and want to learn to do something new. But that is the most important part. And one last thing is we started, and actually Mike works at Community and Health Network. And when we first started the COVID pandemic, the Indianapolis Coalition for Patient Safety, the CMOs and CNOs met, I don't even know how many times a week, so that we all stayed in touch during COVID and try to keep our same standards of care, visitation, PPE, our policies and procedures similar. And I heard Jean Putnam, the chief nursing officer, talk about a concept called helping hands, where people were stepping in to help out in different areas. We started that later. We started that in our last big surge of COVID, and it's still in place now. But having helping hands with expert nurses that may only want to work 4, 6, or 8 hours versus a traditional 12 hours to help come in and help new nurses to learn things has been very, very powerful for us as well.
Thank you, Leanne. That was great. Stacy, can you add to that?
Sure. Thank you so much for allowing me to be here today. You know, a couple things to just, add to what Lee was saying is, one, we would say that training, transferring the knowledge is incredibly important, but also the communication. I think that, we are going through, and we have been through difficult times, but it's incredibly important to acknowledge that. And, one of the things that, on the side that I do is I teach at the nursing school, and, we're thrilled with some of the infrastructure investments that are going to be made, and sharing that, with your team, if they're not aware of that, I think is incredibly valuable. The other thing that we hear of, not everyone can do this, of course, because they're at the bedside, but, ensuring that, where we can, we continue to have flexible arrangements, but we still can gather together as a team. We still can have huddles over Zoom if we're not at the bedside and we're able to, to tap into Zoom or Teams. We can still collaborate with each other. And that's incredibly important to not forget those things, because it's so easy when, perhaps in some roles you're working at home and you're thinking about how do we really connect? We can absolutely have the same sort of connections and develop those deep personal relationships, which are really, really important. I believe that firmly, that relationship is incredibly important. And it's a place, just like Lee had mentioned, to really share information and, to share some of the concerns, some of the training, some of the things that we can do, and some of the things we can pass along. And then remembering to meet people where they are. If they are in the hospital setting, perhaps at the bedside, not forgetting some of the best practices of rounding, being seen, even in difficult times when we have to do other things. It's incredibly important, if the institution allows or organization allows, to have leaders round and to hear those and ask for those, ask for the input of those tenured clinical staff, nurses, and all other staff that are in the hospital. Get their feedback of what's working, what's not working, as far as training what we say the next generation, so to speak, so we can, connect them And then finally, Lee mentioned this as well, but I think it's so important, we have to mention it again, is having a more of a mentor relationship. When you have newer clinical staff, it's incredibly important, to tag them up with somebody who's more tenured, and not to forget, nursing may be different today than it was in, 20 years ago. There may be some changes, but we can learn a lot from each other. New nurses can add a lot of value, things that they've learned, but also our tenured nurses and clinical staff, they can provide us deep knowledge, but really putting people together. It's almost like assigning a group. And sometimes it's that leader trying to get the individuals together rather than, well, just go find somebody on your own, because that's difficult in a mentor or mentee relationship. All those things, I firmly believe will add a lot of value in transferring the knowledge and supporting the clinical staff where they are and being flexible. We know that, we can always say that there's been a lot of flexibility. People have, been allowed to work at home. But when you're at the bedside, can we do things and continue to do things and look at things differently? And that's one of the things, looking at the hours, I would just tag on to what Lee said, is because it's so important. Is it a 10-hour shift? Is it a 12-hour shift? Could it be 4 days if it's a 10-hour? Could I come in at 8:30 versus 7:30? Could I look at how things are done differently and then meet each other so they can, transfer the knowledge and work together? And can I set aside time in my day to do that with meeting those flexibilities in schedule? I think those are a few things that I would just add for the long term of how we can really work together to transfer that knowledge.
I think that's great, Stacy. So from both of you, what I really heard was certainly those transition to practice programs, which are so important. Many of us who have worked in the nursing field for many years recognize that new graduates today are a little bit different than they were maybe 30 or 40 years ago. And there's many reasons for that. It's not really a criticism, but we do need that transition to practice program. And I know we also have an RN transition to practice and a post-baccalaureate transition, as well as advanced practice transition programs. I think that's probably going to be one way that we can support that knowledge. I also heard both of you say that education and creating experiences, what I wanted to add was the use of simulating experiences so that we can help these newer graduates gain the experiences, not necessarily through live experiences, but through simulated experiences. And many of us have attended conferences in the past several weeks. There have been several national leadership conferences, and my team and I huddled recently and talked about the topics. And what was fascinating was that the topics were very similar, and many of them did touch on this subject. But looking at that flexible work schedule and what does virtual work need to look like in the future? And so I know that here at the VA, we're going to be looking at some opportunities to create actual bedside positions that may be somewhat telework, looking at perhaps tying some of that expertise into rounding using computers, iPads, and the technology that we have. I think there are also opportunities to look at technology as we use in many of our ICUs, looking at a telemetry connected or a telemedicine connected electronic ICU or a tele ICU. So you have the additional knowledge support. We may need to do that in other environments as we continue to navigate the next 5 to 10 years. And by all predictions, we're looking at a good 10 years at this point. And that prediction was made before the pandemic. So I think all of us who are leading healthcare organizations really have to remember that as we move forward and come up with some creative strategies to maintain recruitment and retention efforts throughout so that we can continue to deliver that high quality evidence-based care. Anyone else have anything else to add to this question about retirement, young nurses, inexperienced nurses, and experience and institutional knowledge before we move on? So our next question, tell us about staffing strategies and how COVID-19 has impacted that. Stacy, I believe I have you on to lead off on that one.
Thanks for that question. And, I think that's so important, looking at your staffing strategies. One of the things I just mentioned, but I couldn't say enough, is really looking about the flexibility in your work schedules. How can that look a little differently than how it has in the past? How can we really meet the individuals working for us at the bedside, and also looking at some of the staffing strategies where virtual actually comes into play as well. And, Christina, you just mentioned that, but I think those are a couple things that I would say just are so important to look at. And also surveying, asking, not necessarily sending a survey out, but really deeply asking our individuals who work at the bedside, what's important to you? What would be helpful in your position? Is it more flexibility in the schedule, more virtual arrangements? Thinking about, our staffing strategies are really directly tied to our retention and our turnover. And so asking, when we go directly to those individuals who work for us, what's most important to them? Sometimes we think we know, we think we know the answer. We think it's, well, you do want to be virtual. Lots of people do want to be virtual and remote where they can. However, when we ask that question, we may get different answers of things that are important to them. So that's one, staffing strategy. The other, I don't, I say it's a strategy and it's not, but it's so important. It's training. And I can't say that enough. And because what happens is when newer folks come into the area, they may just be newer to the organization. Not having the right training can lead to some turnover. And then that causes some other staffing issues, which is really, in my opinion, being proactive and ensuring that you have the right training programs in place, the right mentor relationships in place, and working together. That can lead to a great staffing strategy. And I really think, that communication between the two is so important. And sometimes we miss it. We get so busy that we're like, we filled that position. We're so excited. I needed, 3 nurses on the floor. Or I needed 4 positions of this. And we want to get everybody in, roll up their sleeves and ready to go. But then we forget the training piece. And lo and behold, 3 or 4 months come down the road. We're like, that person's really not performing the way we anticipated they should be performing. And some of it comes down to training. And that really is a staffing strategy, because we want to retain our current staff as well as, obviously attract new staff to our organization. And, with both of those items, that's going to help. The final thing that, could be answered on either one of these questions, Chrissy, that you mentioned is getting back to what I call some normal of attending conferences, supporting education, making sure that, the staff has the right credentials, they're able to take the time they need and participate in. If they want to go to a conference and that's something they did, prior to the pandemic and they haven't done in a while, that we support that. Even in difficult times of, staffing shortages, how do we support our current staff? Because the last thing we want is our current staff to turn over and leave our organization. So in my opinion, when you're addressing staffing strategies, it's not only about attracting new talent and telling the good story of our organization, because there are lots of great stories about all of our healthcare organizations, and we should tell those stories. Our employees should tell those stories, and we should promote that. But it's also making sure we can retain folks internally. And we have to be careful even with all of that, because we want to make sure that we have equitable programs across the board for everyone, that they can participate at some level in those programs. And those are a couple of things that I would just mention as staffing strategies, because our goal is obviously to keep the individuals we have today that are performing very high for us, and obviously attract new talent, even in a challenging market where we know that, there are challenges finding the right people. But I believe if you make some of these changes or use these best practices, it'll really help your organization.
I couldn't agree more, Stacy. And you mentioned education and training, which can be really difficult. And I know, Leanne, you would agree with me. When you don't have sufficient baseline staff, how are you going to find staff to do that training? some of the strategies that we used during COVID-19 and that we've continued intermittently as our population has fluctuated up and down over the past several months is we did something called nurse extenders. So we had nurses who were specialized in other areas come into areas that they were less comfortable with. And we called them nurse extenders. We said, there are things you can do regardless of where you work. You might be an outpatient procedure nurse, but you can still do vital signs. You can still help turn patients. You can do hourly rounding. You can do assessments. And so we were able to increase our baseline nurse patient ratios, but add people to the teams. And so it became a much better model for staffing, especially when you were extremely short. And there are times where we find ourselves so short-staffed simply because of vacancies and or new or less experienced nurses. And bringing an experienced nurse into that area who is just another pair of hands, but a pair of hands with a tremendous amount of expertise has been very effective. And I think in the beginning, we hesitated a little bit, but we found that it was a very good model to follow. Early in COVID, we used some unique staffing strategies where we created more of a team model. And I think many of the community hospitals did the same thing. We brought LPNs, nursing assistants, a variety of different team members back to the bedside and said, you're going to work as a group and we're going to care for all of these patients together. And it worked well. I'm not sure it's sustainable from a fiscal responsibility standpoint because we analyzed what it would cost to do this on an ongoing basis. It said it may or may not work effectively or efficiently. However, the RN extender piece is a good strategy that really did come out of COVID, because I don't think before that we would have been so free to do that, to bring these RNs back into a different environment. At one point, we even brought our nurse practitioners and said, if you want to work over the weekend, because they said, we want to help. We want to be, we work Monday through Friday, we're available on the weekends and we can still think. And so we had a lot of people coming back to our clinical units and they really did build that team pretty effectively. So that was exciting when it comes to those staffing strategies and COVID-19 and how it impacted creative thinking is what I believe happened. We had to get creative, and we're going to continue to have to be creative over the next 8 to 10 years as we navigate the nursing shortage and our opportunities with retention as well. And we have to recognize that there are attractive opportunities for all of our nurses. And we recognize that they may work in independent roles through contract agencies, et cetera, a little bit more freely now than they did maybe 5 or 10 years ago. So it's a cyclical, challenging problem right now. Anything else from the panel related to staffing strategies and COVID-19 before we move on?
I do have one comment. We did similar to what you were talking about where I practice, where you said we created teams. There was a lot of value in those teams and what we learned from each other. And it wasn't just nurses, it was also pharmacists, respiratory therapists, although they're shorter than nurses actually in the shortage world, but also the therapy team, physical therapy and occupational therapy. And their help in the beginning with COVID, especially with all the proning that needed to occur, they were exquisite. And out of that came really a role that we transformed some of our patient care tech roles into mobility techs. And that has continued to this day. And in our helping hand shifts that we have available, many of our therapists still help us out. And it's really created a sense of teamwork as well as a sharing of knowledge. The therapist's knowledge of your movement and your mobility, we've always had that relationship, but this has brought it a little closer. So I like that approach, and I think it's really helped make a difference in the just overall mobility and some patient care outcomes that have to do with, hospital-acquired pressure ulcers. And then just the simple act of getting up is one of the Florence Nightingale, let's get up and move, let's deep breathe and eat good food to our best of our abilities. The second is the helping hands and what we talked about. And then I think Mike, I kind of want to hear from Mike, but the way the emergency departments have staffed in the past, they flow more. They bring people in as the volume goes up or as needs arise. And I think in nursing in the hospital and even in the clinics, we've been more hesitant to have traditional 8-hour, 10-hour, 12-hour shifts. But this model of bringing folks in at different times to help with the flow of patients and really looking at it carefully, I think that is really a great strategy to help with new and creative staffing models.
And Ben, you're correct. It is very predictable from an ED volume standpoint of when patients arrive. So to build your staffing model around their arrival by time of day is rather straightforward, even during a pandemic. And it really puts the resources where the volume is.
Yeah. And that's a way we have not traditionally in nursing. We've had these, I come at 7, I leave at whatever time those shifts are. And I think we need to think differently about that based on our patient care needs. So that, and then bringing in other professionals to help us. You called them extenders. I like that. I love the helping hands concept as well. So I think just thinking differently, and I'm really intrigued about what you said about the telehealth with we've done that with ICUs, but have we done it in other ways? We use video monitoring for all of our patient rooms here for patients that might do harm to themselves or elopement. And that has also been a great strategy to provide care, but can we even do more with it? So I like that. So thank you for sharing that.
Certainly. And I think there are many exciting possibilities. And as Leanne just said, we have to stop thinking the way we always have. And for some of us, that's difficult. But I think we really have to think outside the box and look at what could we do differently? And how could we make this work better for our patients to deliver a much better product of healthcare? So Mike, since you jumped in there, let me start with you on the next question. With nurses being on the front line of healthcare, they often recognize potential issues before leadership. In what ways do you create a safe space for our frontline employees to come to leadership with these issues? And how do you generate innovation from employees?
Thank you. Thank you for the question, and good afternoon, everyone. I think one of our biggest focuses here at our network, and I'm sure many organizations, is really to get our team members comfortable with speaking up for safety concerns. Oftentimes it's hard for even management and leadership to step in, hold someone accountable, but we're asking our staff and our team members to really, what we call here, speak up for safety. It's almost akin to if you see something, say something before the safety event occurs, whether it's a potential fall or you see somebody going into a room that maybe hadn't washed their hands. It could be any number of things, but really getting the staff comfortable and that it's all right to stop anyone and ask a question. And we've set up a little acronym, ARCC, which is really ask the question, make a request, voice a concern, and try to remedy it in real time versus reporting it after the fact. And it's a work in progress, and it's not comfortable for everyone, but it's something we continue to emphasize as a network to really speak up for safety. And of course, the traditional route, if it's not working, the other part of that C was, chain of command. Sometimes you'll have to report it if a safety concern, does come up that needs to be reported. We do culture of safety surveys periodically to really ask our team members, how are we doing? Are you comfortable, doing this? Are you listening? And then we get to those reports and we make action plans off of those and what areas that we can improve, which we do have room for improvement, but really getting the voice of our team, as to what they feel, if it's an environment or not safe to report these kind of things. We have safety lines, an anonymous safety line where they can call, any team member can call a voice, a number and leave a report if they don't feel comfortable, stopping the individual themselves or even going to leadership. So there's an anonymous safety line that we have here in our network as well. Some units, ours included, we've placed a lockbox on the unit for any safety concerns, anything that staff want to report to management, but perhaps don't feel comfortable doing so, and we have our patient care coordinators check that, pretty frequently for any safety concerns whatsoever. And it is utilized. I wouldn't say to a great extent, but it is utilized. Our organization, much like others, have an electronic safety event, reporting system, and all of our staff have the ability to, make entries into that electronic record. And what I like about this is every entry that a staff member makes about a safety event or a concern has to be followed up by leadership, has to be closed out, has to be investigated, and it could be anything from a fall to, anything at all that the staff feels is a safety event. And then each morning, at 8:30 for us, but every hospital in our network has safety calls to review those entries, to share safety concerns. And that's every morning at 8:30, around the clock, and it's usually manager or director level, but anything that staff enter into the PACER events will get investigated and talked about at our safety calls on a daily basis. And then our network also has a network safety call that takes all of the individual hospital-based safety calls and really reviews all safety events on a daily basis, both at the hospital level and the network level. You'd ask about generating innovation from employees.
Mhm.
Yeah, I think the one thing that we emphasize here and at other organizations, magnet organizations and such, is really the shared governance model. Oftentimes it's the frontline staff that have the solutions, have the knowledge, and they should be allowed to make those decisions. And it benefits the department and the hospital. It hardwires processes faster. They feel more involved and more engaged. And I can just share you briefly from our department. Our emergency department is a pretty large department, about 175 employees, and we have an 18-member practice council. And that's made up of RNs, techs, medics, and LPNs. And they meet monthly. They get referrals from other staff members. Sometimes managers will provide them a problem or a task, to see if they can help come up with a solution. Daily improvement boards. Some of our units in our organization have what we call daily improvement boards. And that's a more formalized way of submitting ideas to the practice councils, for follow-up. And a lot of good innovation has come out just about out of our department. When we built the new hospital, we had the practice council involved in the emergency department design every step of the way. They developed a whole new triage process when we moved into the new facility. It was all staff driven. Management was reported out on, but they chose the flow. They came up with pagers for patients waiting in the ED waiting room, which really made the waiting room much quieter and not as noisy, and no one really knew who was called next. So we'd have to do a lot of the questions of they went back before me and those kind of things that you see in an emergency department. And it was HIPAA compliant and respectful. We weren't mispronouncing names and violating HIPAA potentially by announcing names and stuff. It's just a much more professional approach that they came up with.
Mhm.
Let's see. I think that's, yeah. And I guess I just want to emphasize that the staff should be and do well when they're involved in decisions. So I think having a robust practice council is a great way to really bring that innovation to the forefront.
I agree, Mike, and thank you for all that information. Engaging staff is one of the key factors that we have to focus on if we're going to be successful, not only at recruitment, but more importantly at retention and retaining that knowledge in our facilities. And so looking at all those opportunities to create a safe environment where reporting is paramount, transparency, and non-punitive are very important. Does anyone else have anything they would like to add to that?
I guess it's Leanne, and I want to just call reference, since we are in the aftermath of an event for a nurse in Tennessee that has been convicted of a crime related to a medication error. that I do think Indianapolis is very blessed to have the Coalition for Patient Safety. We met as a group. We started as a group many years ago because of a horrific event. And all of the hospitals in the Indianapolis area are part of that, and have really worked on just culture of safety, no blaming, learning from each other. In fact, every month we share events confidentially and try our best to learn from each other. And I just wanted to say that this past week when we had our board meeting, we all committed to sharing. We all have responded in words that work for our staff to help address that the concerns. There has been fear, and there is a very strong commitment from each of our hospital organizations in the greater Indianapolis area to continue to support a just culture, that blaming and is not a way to make effective change. And so I just wanted to mention that as well. And I know I've seen, we've all shared and seen each other words that work, our communication points, and they've all been very strong in that regard. So there is a strong culture in our community for safety, and having a safe environment where there's transparency and that just culture is one of the strongest ways to ever engage with your staffs. We work in healthcare, we're human beings taking care of human beings, and incidents and errors do occur. And if we do not learn from them, then shame on us. But I think that approach is also a very good one for staff engagement in healthcare.
Thank you for adding that, Leanne. I was thinking along the same lines when Mike was chatting, because it has been very, very difficult to bridge that gap, and more to come, I'm sure. It's not going to leave us very soon.
Yeah.
So the next question we have, and let me remind our participants to be thinking of your additional questions. What creative programs or initiatives have you used to increase engagement among clinical staff or to reduce turnover? Second part of that is, what are some unique incentives that you use to increase productivity among your clinical staff, like time off, bonuses, competitions, other than standard pay? And I'm sure that we all have some unique approaches to this, and it will vary with each organization and what we can do within the constructs of restrictions. Who would like to start this off? I will call on someone. Stacy.
Well, when you chime in and say what unique incentives, I mean, there are so many other incentives that you can actually use besides base pay. And I even believe outside of bonus pay, because bonus pay was used a lot during the pandemic and probably continues to be in some organizations. And I'm always thinking what's fair and equitable for the folks that we're recruiting, but also for our current staff. And I think there's a lot of different things that we hear, at least, and when we're talking to staff and with our own staff, that I think about. So a couple of things I'm thinking about is, going back to when they're not at the bedside, offering that flexibility, that is critical. And we've had some organizations even change that policy more recently, where they may have had folks in 2 or 3 days a week and they're reducing it to 1 day a week. These are things that really retain individuals because they are comparing different roles. Now, when you're at the bedside, I'm going to say, and I think this goes for all staff, and this is something we always do, and we hear really good feedback on, is we do handwritten notes. I've done it for years in my career, and it still works, and I share it with, my son too, because, writing that note makes a big difference. And, obviously sometimes we're putting a gift on it. It's a thoughtful gift. It's something that we're purchasing for them. And sometimes it's just a note to let them know, we're thinking about you. We appreciate what you do. And it makes a big difference. And I can tell you the times that I've received a note in my career, I know exactly when that was, what month it was, what year it was, and how it made an impact. So that really is another way to really, highlight. And then what can you do for the team? What's in your budgetary constraints that you can do for the team, where you can include all individuals? And are there sometimes some things that you can even highlight somebody who's, shining in the team? I think it's so important that we provide constructive feedback, but also we should, provide those positive outcomes and share them among the team. One of the final things I like to do is and I think this really leads to, it's not necessarily something you give, but it's giving in a different way, is sharing personal stories. So there's two ways to do that. Your connect to purpose story, which is, why am I here, right? How did I get here? Besides going to school and getting this position, but why do I really connect with the patient? And how do I really connect with the patient? And the other is your personal journey in your organization. A lot of individuals may not know how long somebody's been with the organization. So I think it's incredibly important, and especially those individuals who have been promoted up. Maybe I started on the floor as a nurse, and now I'm a nursing manager, and I love it. And I've been with the organization for 7 years. These things, I think, often really help in an organization with more engagement. It's not something that costs us a lot of money, but it's something that really means a lot, because when you do see individuals turning over, it's so important that you highlight the folks that have been there. Or on the flip side, if you have a new leader in your organization, you can say, well, the leader that this person's coming in was here for 20 years. We're really excited for this leader to spend the rest of their career here, spend the next several years here. I think that promotes engagement too. But I can't say enough, and I probably spend a lot of time on communication, but communication, in my opinion, always promotes more engagement, higher retention, and doing some of the small things. People will always take money, right? They'll always take big bonuses and those types of things, right? We're all human, we're going to do that. But it's those small things that really people remember, and it sticks with them. The small things that you can do on a regular basis, it could be the birthdays or the anniversaries, or just because. And I think when you do those things, it really does promote a more engaging workforce and higher retention within your workforce. And those are a few suggestions I would have.
Thank you, Stacy. That was great. Leanne?
I was thinking about when I think incentives, and we certainly have used incentives that are money, and money that reflects if you work even more, you're recognized, or it's the toughest shift. One of the things I've noticed with our new grads this time around, because money seems to have sort of maybe evened out just a little bit. Now it's like, I want to work in the great environments like a ER or the NICU, and I want to work day shifts and no weekends. So you're like, okay, well, we got to go back and think about this. So, but it's the money incentives did help us a lot during COVID, but really the right thing for incentives, I think, is to make sure you've got the right number of staff to take care of patients and fix that issue. And so I think that's where I see most of our healthcare systems here and across the country, is we've got to help fix the fact that there are a need for healthcare workers in all areas. And I'm not just talking nurses, I'm talking all of the supports around it. If you don't have a respiratory therapist, or you don't have environmental services, or you don't have food and nutrition. So that is, I think, the work that I see happening and going on. And that is a big incentive to folks to make sure that they have the right supports at the bedside. And I see lots of efforts of starting as early as you possibly can to really grow your own, either in nursing or grow your own within different areas of your hospital, and really reaching out and providing good clinical rotations and opportunities. So I think that, to me, is the basis of a lot of things that are happening here now to help with incentives for staff. But I will say, I really, Stacy, all the things that you mentioned, I think those are just evidence-based best practices, rounding, thank you notes, connecting with folks, sharing your stories, sharing them in your huddles, sharing patient stories. That creates a sense of family, creates a culture of the purpose, what you call connect to purpose, or the why we're here. Those are all excellent. Now I'm going to throw a few other little incentives in there, though, that I was, and I still am, I guess, pleasantly surprised. So where I work at, my boss is the CEO is a physician who is strong believe in food is medicine. We did a lot of things with food, and we have a very creative food leader that is food strategy, community feeding, and the food nutrition within the hospital. But food is huge, and staff, night shift staff, they want really good food, and they want cheap food or free food. And that's exactly what we've done. And I'm surprised at how much that means to folks. We started back very early on with adding what we call recharge rooms on each and every patient care unit. And it was a place to put drinks first because all that PPE was so hot. And that has continued to this day. We stopped it for a hot moment. We had that lull last summer where it was kind of nice. Oh my goodness, you would have thought the sky had fallen. So we went back to doing it, and will, I believe, continue to do that, because the work of people in healthcare, it's hard, it's hot, it's sweaty. And so you see people coming in and out all the time in those recharge rooms. We also filled them with the positive notes we received from patients and everybody, first during COVID and now what happens on that unit, and then that's the place where we provide snacks or food during that time. The other thing that we had before we started COVID, but we've started back up, is our pet therapy program. And you think people would not, you're like, oh, pets. People love pets, and we have I think over 60 that are now coming back into the hospital again, and the patients love the pets, but the staff love the pets. And having this one in particular, I love Gus. He's kind of my guy. Gus, big fluffy Labradoodle, will dress up and let you pet him and just love him. And I can tell you, the nurse that takes him on rounds, one story she shared with me just recently, they went to the ER and this patient had a very bad outcome, and it was all before it got to the hospital, and the family member was there, and the family member saw Gus and went out into the hallway and just grabbed Gus and laid in the floor and cried with him. So the pet therapy is huge. And then we have music therapy, and we've also started that back again. And the music therapy is more important, I think, to the staff than to even the patients. So those things that you think are, you just don't think that they will make a difference, they really do make a difference, and they fit in the culture of who we are. And it's almost sort of like being at home. You love your pets, it's kind of nice to have them at work, or you love music and it's kind of nice to have that at work. So those are some unusual things, but the food, and I will throw one other thing out there. We used to have this we went to this formal, you got to wear the right scrubs, you got to look this color, all of that. That went to heck in a basket with COVID. Well, not really, but we did not allow t-shirts. T-shirts are also one of the hottest things. So when I need a shift filled, I will offer food coupons and a t-shirt. I'm now on my 6th color of approved. Of course, it's got to be approved colors for our hospital, but approved. They just came in today, and the shifts, people will sign up for the shifts for those kind of things. So we call it our swag. Like the first 5 that call in get this as well. And so that also works. And I never in 100 years would have thought that those would have made a difference, but it actually has been kind of fun to see.
I think those are great, Leanne. A lot of things that I had never thought of. So thank you for that. we may have to duplicate some of those opportunities. Mike, anything else to add? These are great suggestions.
And I'd just like to restate the emphasis of the employee rounding. I think to have a productive workforce, you need to know your workforce. And, one thing we do here, is I really encourage our managers to get out and round with all of the employees. Not hi, how are you, and walk by, but really engage in a conversation, as often as possible. And I think it just adds a tremendous amount of value. I know myself, I'll meet with every new hire that comes into our department, sometime within the orientation, just to start building those relationships, because I won't be directly as involved, obviously, as a manager with these employees, but I do like the rounding with employees is huge. Where it's more than just a hi, it's really getting to know them and for them to know you. A couple of just, interesting incentive options I just wanted to share out there from our perspective. During January, at the peak of the third bubble or third curve in COVID, we were running into some barriers with getting shifts filled and people kind of getting burnt out a little bit. But we added we gave gift cards out at the end of their shifts as an incentive, to work, and really surprised by the success of it and how many people really would start signing up for shifts and filling shifts when they knew they could walk away with a gift card at the end of the shift. Getting, something in real time, tangible for coming in at the last minute or filling that last second hole was pretty well received by the, nurses and, technicians in our facilities. I just wanted to add those two, but thank you.
Those are great. And the only other things that I thought of, one was the Daisy Award, and I'm sure many of us do recognize Daisy Award winners. And for those of you who are joining us today that are unfamiliar with it, please do take the time to look it up. It's commemorating a patient in great nursing care. And we actually, believe it or not, had the daughter of a patient design a daisy wall for us and hand paint a painting that then we were able to create into a background. So we have it in our main lobby and it is just beautiful. So if anyone wants to come in and see it, it's gorgeous. Leanne, email me and I'll send you a picture. It really made it special, because prior to that, it was the award, it was that one moment, but now it's memorialized in the main lobby. And the nurses do love that. We do very frequent Daisy Awards. We do something called an ambush, where we actually surprise the nurse with a big banner and the gifts that come with it and the recognition at the beginning or the end of their shift. We usually have 10, 15, or even 20 people that show up on the clinical unit and ambush the person with the Daisy Award. And we read the nomination, what the patient's family said. That has been really, really key. And I agree with all of you about the rounding. We also incorporated stay interviews. So interviewing every staff member for 10 to 15 minutes every month, asking them, why do you stay here and what can we do to keep you here? We found that those are very effective. We're not at 100% yet, but we're trying. And so we do recognize that some people have said, if you just asked me to stay, I would have told you what it would take. And so we're trying to change our approach as well. So I think all of these suggestions are great, and I'm hopeful that our audience can incorporate some of them into their own facilities. So the next question is, does your facility offer any sort of ladder program or ways for clinical staff members to further pursue higher education, credentials, etc.? Leanne or Mike? Sure.
I'm sorry. Sure. Our organization, of course, with the standard HR, some policies and tuition reimbursement supports continuing education across a pretty wide spectrum, both part-time and full-time. And it's eligible on the day to hire. So, you don't need to wait a year before you would be eligible for some of these educational benefits. And then some of the professional certifications are paid for as well by the clinical staff, and even leadership certifications. We have a variety of different programs here, but I think two that are worth emphasizing is our RN professional development program, similar to a clinical ladder program, but with some nuances. It is designed for our frontline RNs, really to try to improve safety and quality, while with a focus on retention, and without getting too much into the weeds, it's really a 3-track system that our RNs can apply for at the beginning of the year. And based on, the level they really want to strive to receive, the things they can do to, improve their continuing education, be part of some evidence-based practice and lead projects along those lines. Things like that can get them to the certain levels, and based on the number of interactions and involvement that they have, will determine what level 1, 2, or 3 that they would be part of at the end of the year. And it's a kind of a yearly cycle. They would reapply, indicating what they're going to do for the following year. And we also have a new program. It's a MA to RN program through Ivy Tech, and we have sponsored 12 medical assistants / technicians to go to and pay for their tuition in full, pay for their educational days off, in a way to bring new nurses into this pipeline and retain our medical assistants and technicians as well. And there was a lot of demand for that when we rolled it out, and my understanding is they'll definitely be expanding that again next year due to the great desire that they saw this year. And then we also get, as far as retention, they'll be with us for the next 3 years, as an incentive to the organization as well, as keeping our individuals here with us.
Mhm.
Just a couple of programs that we have here at Community Health Network.
Those are great, Mike, and thank you. Leanne, what types of programs are you offering?
Well, we do have the tuition reimbursement, as Mike mentioned, and that's a very, I think, a wonderful program, especially when you think if someone comes in as, like, let's say, EVS worker or a patient care tech or registration, you have access to tuition reimbursement that can help you further your career for healthcare roles. I always, when I talk to students, I say, come do this because your parents' student loans will be way less if you have tuition reimbursement. So that's one of the programs. We do have a student nurse extern program, and I've been at Eskenazi about 17 years, and it's been in place longer than that. But that is really the backbone of bringing folks in their junior year of nursing, and they spend a whole summer with us. And I would say we retain a high percentage of folks that do that program. And in fact, many of our experienced bedside nurses, shift coordinators, managers, and even directors and associate CNOs have been a student nurse extern at the Old Wishart or Eskenazi. And then we just started the program that with adding to the student nurse extern program, a student nurse assistant. So keeping them working with us formerly would have been like a patient care tech role, but allows them to do a little bit more and be paid a little bit more in that role. So we're real pleased with that. And then lastly, we started in 2009 a career ladder program, and I have about 1,000 nurses at Eskenazi, and we start off with about 25 people getting it in 2009, and now greater than 20% of the staff do. New to that career ladder program, and I didn't think people would do all the work that they had to do for that during the COVID pandemic, but they did. And in fact, this last year was our highest number ever. But we added, it used to be, we do follow the Benner model for professional development but we decided, because so many of what we're reading in the literature and seeing ourselves is that the first year nurses are the ones that leave. We started our career ladder program at the end of 2 years, and we decided this year to start it at the end of the first year and really do more strategies and have things in that career ladder program to engage with that 1 year to 2 year RN, and especially thinking about what patient population or area of service that they want to work in. I think that's going to be a lot of fun. We did also implement for our CSTs and for our respiratory therapists also a career ladder program, because they're also a group that we really want to cultivate and keep within our departments. Those have both been extremely well received.
That's great. And so it sounds like we do have a variety of career ladder opportunities in our different hospitals that nurses can choose to participate in. It does require some extra work, but it's also that incentive. And most of them are tied usually to a slightly higher salary or time off in some instances. But those are great ways to incentivize your staff to stay with you, because certainly if they're engaged in higher education, certifications, and or performance, they're more likely to stay with that organization. Does anyone have anything else to add before we move on to the next question? So our next question is, how has your organization worked with, or have you worked with, external professional associations to help improve retention amongst clinical staff? And that's basically for all of us. And some of the examples might be our incident command, emergency preparedness, readiness, retention, all of those working with external agencies. And I think I'll start here with this one. Because the federal government is so connected with FEMA and with all of the training programs, we have a rather robust incident command system that is fairly nimble. We can stand it up pretty quickly, usually within a very short period of time, and we're successful. But during COVID, one of the unique strategies that we started with, when we recognized that this was going to be more of a clinical emergency, and many times our officers or our chiefs in our incident command structure are more support structure than clinical. So very quickly, within the first couple of days, we realized that was not the best model, even though it was the common model. And so our operations chief ended up being a nurse, and not myself, because I had other things to do at the time. It was actually one of our nursing supervisors who stepped in as operations chief. And over the next couple of weeks, as we began to build the structure, which of course stayed up and active for many, many months, we had nurses, different levels of nurse managers, step into the training role and learn how to be, because 24/7, the same person can't always be the operations chief. And we were able to engage a tremendous amount of our staff in incident command, which I don't think happened before. And what it did was, as we came back and stood up incident command for either other incidents or a resurge in COVID, we had more individuals that felt comfortable with that incident command system. And we were partnering with our professional associations and our professional guidelines for incident command to do that. But we deviated from the past quite a bit, because most of our incidents in the past have been building related, pipes breaking, fires, floods, etc., as opposed to a pandemic, which most of us, if not all of us, have not really had before. I did Ebola, but it never came, so I don't really count that. We were just ready. So when you think about what we did, I think partnering with those facilities and thinking differently was really very important. And some of our staff, in fact, I can give you a great example. One of them was in grad school. Her clinical activities were paused. She was looking at graduation, thinking she was never going to get there. We were able to negotiate with the school and her advisor, saying this particular experience fits the clinical experience for this course, and it did perfectly. And I ended up being her preceptor. So I mean, when you think about that type of opportunity, and obviously still here today because we've worked with our staff and tried to make sure that we can partner with those organizations. I think that's one of the best examples I can think of. And she did graduate too. So, a lot of students really struggled during that time. Other examples of partnering with professional associations.
I think I'll speak up. I do think the Indianapolis Coalition for Patient Safety was a really strong one for us at Eskenazi. And the other thing I've noticed, not only was it helpful during COVID, but all of the work groups remained active. They were active by WebEx, but things still happen. Under medication safety, the maternal work group was able to just implement some really great bundles of care around that patient population. The sharing of events, ethics. We're in the midst of one now as a community that I see working extremely well. And I'm not sure I ever thought I would see this happen, but We have a group that's comprised of ED medical directors and nursing operations directors. Mike, I'm sure you're probably on that group, but we made a decision. The amount of diversion before we went into COVID in our city was huge. And in fact, Dr. Dan O'Donnell from the Indianapolis EMS had come the very day that we were talking at the Coalition for Patient Safety to say, let's work on this as a community. And then doggone it, it was COVID. And we talked that same meeting about what we're going to do with ventilators if we don't have enough, how we're going to make those tough decisions. So it got put on hold. And of course, COVID stopped a few things, so we weren't on as much diversion. But this last summer, and then going into the winter months was absolutely awful and terrible. And so we decided through that work group and the CMOs, CNOs, let's just try this out and see if we go to no diversion, will it work for us? I think that started in, was it February-ish, February of this year. And we started for, I think, 30 days, and then we added 60, and then we added 90. And I think we're going to go to sometime in June now. But it does appear that it's working, and we are not on diversion. And I think that kind of coming together and that kind of an organization focused on safety, I just think that's reflective of who this community in Indianapolis is here. So I think that's been a really great strategy. I can tell you that the ER nurses, when we first walked through and they saw a couple weeks of this, if we could all hugged each other, they would have hugged us, because it's really a wonderful staff satisfier, because it's a wonderful patient satisfier. And when your patients are happy, your staff are happier too. So that's an example of something I see going on right now in an organization, and how we use it to promote safety and helping each other.
Leanne, that's a great example, because of what I've seen at not only our ED and hospital, but others, is it's almost been rather liberating. There's not this constant obsession with who's on, who's off, why don't we go on? We had 3 ambulances. It's been a very much calmer atmosphere. It's just been an acceptance that everyone's going to be busy sometimes, and everyone's not. And it's really taken away some consternation that would occur between physicians and nursing staff and leadership. I think it's just been it's been good, and I hope it continues.
Me too.
Great examples. Stacy, anything else to add?
I'd probably add 2 different examples is, one, when we think about incident command, having all of the right people on that group. I think sometimes in the past, we often, it's easily, we identify all the clinical staff, and there's a great rotation that goes there. But then when we need something and we're in a critical situation, having all of the right back office, whether that's an IT representative or whether that's a person from finance or supply chain, that may be critical to incident command, to executing on something that is critical for the healthcare organization or for all healthcare organizations. So thinking through that and collaborating, rather than, we realize that, oh, we're in the middle of a crisis, and then we're like, who can help us execute this? So, having that collaboration cross-functionally across all teams, the back office and those who support us, as well as the frontline leadership. And the other thing that's a little different, but I think it's so important to mention, is collaboration. Even when we look at external professional organizations, one of the things that, sometimes we're asked to, speak at different organizations. And every time we are, I'm thinking of one we have in September out in Phoenix. I reach out to my partners and those in the clinical setting. I don't pretend that I know all things as it relates to the work that they're doing. So I ask, who would like to come and speak on a panel and be part of this? And really, when we reach out to folks like that, they get really excited. They're like, I haven't been to a conference in a while. And they think about, well, this is going to be taken care of for you if you go out to the conference and you're able to speak, but it's a really great time for them. And they actually get out of their healthcare system. They get to meet with other healthcare systems that may be having the same types of challenges. So not only are we collaborating with, our partners, but we're also ensuring that they have time, they're aware of the opportunity, and they can collaborate with other healthcare systems that may be outside of their state. I think that's probably third. It's not necessarily a professional organization, but we see the greatest partnership in helping particularly our clinical staff, but also all organizations, is really partnering and talking to other organizations. There's so many organizations that are going through the same thing, but they would welcome the call. They would welcome the call to work together, whether that's an organization out in Arizona or out in Pennsylvania or in Salt Lake City. We all can learn from each other, and there's so much partnership. And so that's why it's exciting for me when we get to ask somebody to come, because I see more of that. And I think every day we can do that. We can just pick up the phone and call somebody, because I think we see it here. We're willing to share some of those best practices. We're willing to share some of the things that we've gone through in our own organization. And people are very open to that if you make the call to them. So I think those three things are really what I would highlight.
I think that's great, Stacy. We recently sent a few people to a conference as the conferences are becoming live again. And one of the comments from a staff member who returned was, I didn't realize how much I needed that. And so the connection with other professionals outside of your own organization and outside your state from other healthcare systems is invaluable. I think especially just sharing, we're all going through the same thing. The grass is not greener on the other side. It's about the same shade of brown. And so as we move into spring, I think it was really energizing. And a lot of the conversations at these conferences are the same. How do we do things differently facing a nursing shortage across the country? And so I want to remind our audience that as we're getting toward the 5 o'clock hour, we still have some time. We have a couple more questions. If you do have additional questions for the panel, please go ahead and start putting them in the chat room. We're going to answer our last couple of questions for you, and then we will open it up to the questions in the chat room. So please feel free to do that. Our next question is, what have your organizations done to promote well-being? We've been talking about our own needs, retention and recruitment. Let's talk about our staff's needs. What have you done unique? Leah and I loved your recharge rooms, and I was in another healthcare system years ago that had what they called Zen rooms. Yes, it was in the Pacific Northwest. I'm not going to go any further than that, but and we built them into a new hospital. They were actually on every unit, and they were part of what was built into the unit when they built the hospital. And it was the same principle. It was a recharge room, nice furniture, very soft colors, designed by an interior designer with little waterfalls and soft music. And they were not to bring their charts in there or any computers. They were to sit in there and just recharge. There were even coloring books. So the reality is they were valued. And I really appreciated what you said about your recharge rooms. So what else are we doing for our staff?
I can share just a few items here. I know we're running on a little bit short on time. Our HR department had did a real nice job this past year and a half, really kind of retooling and promoting some new programs for our network and our employees, and really expanded our employee assistance programs. By partnering with a group called Vital Work Life, it's really allowed almost on the spot counseling, grief counseling, nurse peer coaching for stress, burnout, team member education coaching, where it's just a phone call away and it's free, so anything from behavioral health to educational needs, all our team members need just to make a call, and they be on the line speaking with licensed therapists if needed. I thought that was a really wonderful addition to our HR department, some of their programs. We also have what's called a RISE team, and the resiliency events. It is a great program when something unfortunately tragic may happen on a unit with a patient, a family, anything that would really cause stress to the caregivers. They could put in this RISE request, and a team of professionals that are trained to really sit down, kind of debrief, find out what happened. offer support and resources to the team members. We utilize it occasionally in the emergency department, a lot of times with pediatric deaths, although we're accustomed to a lot of death, unfortunately, in the ED, sometimes the pediatric deaths really hit our teams hard. And this RISE team, almost has the ability to respond in real time, to talk with the caregivers and really allow an avenue for that communication. And that's something we're proud of here. I mean, unfortunately, use it probably more than we would like, but it's a great resource for our team members to have here.
I like that.
And then the one final thing that, relationship-based care has really been a welcome addition to our network. We've been doing this for a few years now, and it kind of very somewhat of a complex program, but it's a focus on yourself so you can take care of others. Focus on yourself with your teammates so you can take better care of your patients. It's a very broad educational component that we have here at the network, but it's well received and by many.
Great. I'll add first, those are wonderful programs. I love the RISE program concept. We did back in 2016, my CEO engaged with the Center for Mind Body Medicine, and we trained hundreds of our staff to be self-care advocates, as well as to lead classes with self-care. And that has really taken off a lot during the pandemic, and not only here, but also the two that chair at Father Rob Lyons and Megan Hyder-Priest. They now are providing this training in schools, jails, for the jail staff, police departments, and many other places in the community. And it's free to anyone. You have a series of 8 courses that you take, and we pay for the staff to go through it and do things that you learn, like meditation, mindfulness, deep breathing. Deep breathing really works, gratitude, and ways to express gratitude. And by the way, there was just a research study done that showed 3 times at the end of the day, say 3 things you're grateful for. It was with healthcare workers, and the chances for depression, burnout, and suicide compared to the general population is significant. Just simple gratitude. So that is another aspect of well-being. And then we heard this, and again, it sounds funny, but the Calm app, we provided the Calm app free for every employee that works at Eskenazi. I can tell you, I do take advantage of that for the deep breathing. They tell really good nighttime stories, and we put you to sleep like this. So that is a couple other things, ideas that I just throw in there as well.
Well, thank you for that. Stacy, any quick thoughts to add?
I know we're almost near time, so I'll just add a couple thoughts. And one thing that has been very popular that we've done is we've sent spa gift certificates and gift cards. And when those come in the mail, people are very excited because they get to choose, where they would, promote their well-being, or they can make a purchase at the spa. So it's something personally for them, and they get really excited about that. We also do surprise, like little just because throughout the year, and whether it's flowers. And when we first started doing this, I thought, well, could flowers really make a difference? And honestly, it does. It really brightens up someone's day. They're not expecting it. They get really, really excited to receive it. And so those are 2 just small programs that we do. The other thing is we added unlimited vacation, and you might think maybe is popular, it's not popular, but it's extremely popular. So there's not a worry that I'm running out of vacation this year. All the work gets done that needs to get done. And I can't say how much the team has really enjoyed having unlimited vacation and not the stress of, oh, how many days do I have left? So it's been something that's really been very good for their well-being. If I could shut off their email, I would. I think that would help promote some more well-being, but we always have work to do. So, but those things have really, in my mind, really brightened up and given folks, some focus on their well-being, and that we are always saying your well-being is very important to us. No questions asked if you need to take the day off or something comes up.
So we have two really good questions in the chat area, and I'm going to ask them. I'm going to ask us to just be 2 minutes on each question. So whoever wants to jump into the first one, and then we will turn it back over to our hosts to wrap up this session. So the first question is, what strategies have you deployed to address nursing shortages in non-acute care parts of the health system, like ambulatory or outpatient areas? Does anyone want to jump in on that one?
I would actually say we at Eskenazi, with all the primary care sites and specialty care practices, the nurse leaders are engaged with the nurse leaders in the hospital. So we apply almost all the same strategies that we do on the inpatient side. In fact, I can't think of any that we don't. And we did start a Sunshine, you talked Daisy Awards, we started a Sunshine Award for our medical assistants so that they felt included.
I like that. And I would say we have less difficulty recruiting to those outpatient areas simply because of the work-life balance aspect. Even though they're not on the 12-hour shifts necessarily, some of ours are on 10-hour shifts, which that extra day off a week plus all days, no night shifts. It has been, we have difficulty moving people over because we still have people, even though their salaries, we increased our inpatient salaries a few years ago to retain nurses at the inpatient areas. But we still have a lot of nurses that want to. So in one way, they're staying with the organization, not a bad thing, right? But the other way is we still have difficulty recruiting for inpatient. So thank you for that. The next question is, what do you foresee the future of bedside nursing looks like? That is, will the LPN be a thing of the past, or will non-RN nurses like LPNs, health techs, patient support assistants, nursing assistants be more prevalent in the future to supplement the workforce after the pandemic wake-up call? That's a great question. Who wants to jump in on that one?
I'll try to answer that one. I don't think I will do it justice, but I don't see that need going away. I mean, as long as the RN workforce continues to age, which last I looked, I think was the median was 52 years, according to one study, 52 years old. We either need to replace them with RNs or otherwise. So I utilize LPNs. We utilize LPNs in our organization. I think they will continue to have a role, especially as in a team, my opinion, in a team nursing kind of format.
I would agree with you. Leanne?
I definitely agree. I think the care of a hospitalized patient is very complex, challenging, has tremendous responsibilities and requirements. I think that nursing is needed. I love the fact, though, that a statistic I saw for 2021 in the fall is that there's a 8% increase in baccalaureate nursing enrollments. So there is hope for the future. I do think they're having the right supports around the nurse. And I think I'm thinking about people keeping people out of the hospital and at home. There's a lot of roles there for community health workers, medical assistants, those type of roles. But in the hospital, I think it has to be an RN, an LPN. I agree with you, Mike.
Anything to add, Stacy?
I would just say I agree with the same, because I mean, I think the mix of different backgrounds, the LPN, versus obviously the RN, is going to be critically important to support the patient volume that's going to be coming in our hospitals, and with some of the shortages that we're dealing with. So I think training folks at, to do different things like the LPNs are able to support the RNs is critical. And I don't honestly see that changing anytime soon.
I would agree with you also. I think it's going to continue to be a mix of different specialties. I also want to re-highlight that many of us are utilizing those positions as a future pipeline and growing our own. by helping people go to nursing school, whether it's LPN or RN, to further their education while they're working for us. So I think it's also a strategy for the future too. So thank you very much. We really appreciate having the opportunity to talk to everyone today, and I hope you enjoyed the program as much as we enjoyed bringing it to you. I'm going to hand this back over to Sean to close us out. So thank you, Sean.
Thank you so much. Let me share my screen real fast. Thank you to our panelists, our moderator, for such a wonderful event. Some very innovative ideas for retention and recruitment. A special thank you to our IHAN administrator, Corey Jose, who does a lot of behind the scenes work to make our organization run smoothly. Also, I wanted to say thank you to our IHAN programs committee for putting the work in to make this program a success. I wanted to share with you our upcoming events, which should be on the screen now. You have the Promise and Perils of Precision Medicine, Indiana Innovative. Some of this is cut off for me, I apologize. We also have our summit, our HEPE Summit, which is Building Hospitals Tomorrow and Green Hospitals and Healthcare. We have our IHAN Annual Awards Program, Understanding Implicit Bias. And then the last one for this year, for this calendar year, will be Leading Information Safety. So hopefully we can see you join us at some of those other wonderful programs we have this year. Again, thank you for your time today. We value your membership and look forward to providing opportunities to invest in your professional development. With that, I'll hand it over to our ACHE representative for credit reminders and a final send off.
Thank you, Sean. Thank you all for joining today. As a reminder, please fill out the evaluation link, which is in the chat. It'll be open for 1 week, and you can also access it by visiting your My ACHE page and navigating to where you joined today's session. That's also the location where you'll be able to access the recording from today. And if you attended today's event in its entirety, you'll see your credits posted to your account within 2 weeks. That concludes our session, which is copyrighted in 2022 by the American College of Healthcare Executives, all rights reserved. Thank you, everyone, and have a great week.
Thank you. Bye-bye.